Thank you, Declan, and we'll move on to our next speaker. Before we do, I'd like to just remind you of a little bit of housekeeping. So remember that the feedback forms should be used. Remember that if you want an attendance certificate, you must put your email into the toolbar option available after the last break at 3:15. Of course, questions for the speakers can be submitted during the question and answer function throughout. And when that happens, I take note of it and ask the speaker. So our last speaker before lunch, it's a great pleasure to introduce Professor Julia Sinclair from University of Southampton. And Julia's very much an expert, nationally, internationally, on alcohol use disorders in psychiatric settings. And this is perhaps even more important than before because of COVID and the feeling that alcohol use has escalated during the pandemic crisis. So it's with great pleasure that I hand the floor, remotely, virtually speaking, to Professor Sinclair, who's going to tell us about managing alcohol use disorders in psychiatric settings, barriers and solutions. And then, of course, we'll have time for 10 minutes or so of questions before we go on to the lunch break. Thank you very much.
Hello, my name is Professor Julia Sinclair from the University of Southampton, and I am privileged to be here, and thank you to Wiley and Progress and ISAD for inviting me to be part of today's conference. I'm going to talk about managing alcohol use disorders in psychiatric settings, looking a little about the barriers to that and spending hopefully quite a bit of time thinking about the solutions for it. This is my declaration of interest statement. And I think the main things I don't knowingly anyway, accept engagements funded by the alcohol, tobacco or gaming industry or any of their affiliated subsidiaries. So what I want to do is spend a little bit of time thinking about the scale of the problem and perhaps why we don't have integrated care for our patients who have a comorbid alcohol use disorder. And I think that's around stigma and competencies, and then spend the rest of the talk really talking about some of the solutions that there may be for us to do that. And just to say at the beginning that when I talk about AUD or alcohol use disorders, I'm using the kind of new DSM-5 terminology, which includes alcohol abuse and dependence, so the broader spectrum of alcohol use disorders. Just want to start with something that's quite parochial in some ways for the UK audience around current training challenges. Since the Health and Social Care Act 10 years ago, the commissioning of addiction services went out with the NHS into local authorities, and so did therefore many of the services for addictions. And what has happened since that time, therefore, is that we have had a substantial loss of training places, and we currently have approximately 5 higher training places in England outside of London. There's a few more in Scotland. But the impact that this has is in terms of the general psychiatric workforce, perhaps having less exposure to patients with addiction and the impact that that then has in terms of managing comorbid disorders. That's why I'm really pleased to be here with you today. Thinking about the scale of alcohol use within England, I think it's worth just having a quick look at this. 17% of the country drink absolutely nothing at all. And then the majority of people who do drink alcohol, so over 82% of the population, drink at what we would call lower risk levels. So that means they drink at levels less than 14 units of alcohol per week. But it's this group nearer the right-hand side of the slide, which is the ones that potentially we need to be thinking about in patients who use mental health services. We've got particularly those people, the 1 in 5 people who are drinking at increasing risk. So they're not dependent on alcohol, but they're drinking at levels that may be having a significant impact on both their mood, their levels of anxiety and other functioning. There are the binge drinkers, which is quite an unhelpful term, but a group of people who don't necessarily drink every day, but who then will have periods of time when they drink substantial amounts of alcohol, and that will have an impact on their mental state. And then you've got the smaller group of patients, perhaps 1% of the population, a slightly higher number within mental health services, who are drinking at severely dependent levels and who, if they are to stop, probably need a medically assisted withdrawal from alcohol. This is COVID, to bring it up to date. This is data from the Alcohol Toolkit study from last March. And what you can see is that this is the surveys that they've been doing for several years now, about 6 years. And what they're looking at here is the level of percentage of higher risk drinkers. So that's anybody who scores more than 4 on the consumption questions of the alcohol use disorders identification test. And I'll talk a bit more about that later on. But what you can see here is that in March of last year, there was a substantial increase, significant in terms of people scoring at that higher risk level. And unfortunately, something that then correlates with that is in the last month or so, we've had the latest Office for National Statistics data on alcohol-specific deaths in England and Wales. And as you can see from that, we've had about 5,500 deaths related to alcohol in the first 3 quarters of 2020, which is a 16% increase compared to the same 9-month period the year before. And at the same time, as you can see here, the alcohol-specific death rate is now at its highest since the time series began back in 2001. So it's a suggestion that the increase in alcohol consumption has a very quick impact in terms of alcohol-related death, which we know to be true because of the acute on chronic impact that increased drinking has on mortality. But moving on to think about the comorbidity, this is a systematic review and meta-analysis of a number of population-based studies. And it looks at what is the prevalence of mood and anxiety disorders in community populations. And this is where they've had data, as you can see there, for lifetime data or 1-year data for people with alcohol use disorders, and then also subdivided into alcohol abuse and alcohol dependence. And what you can see from this is that people with an alcohol use disorder had twice the rate increased risk of any anxiety disorder and over 3 times the risk of major depression. So, you know, there really is quite a substantial impact. If we think about that from the other way round, this is data from the Zurich study that many of you will be familiar with, Jules Angst's study, which has followed up over many, many years, a whole kind of population of young people and often looking at subsyndromal levels. But in this case, what they wanted to do was to look at mood disorders as a predictor of alcohol abuse and dependence. So the other way around from the slide I just showed you. And as you can see here, that in terms of predictor, if you had a major depressive disorder, you're at least twice as likely to develop an alcohol use disorder, manic symptoms between 2 and 4 times as likely, bipolar 2, 9 to 21 times increased rate of developing alcohol use and or dependence. And obviously being male has a substantial impact over women. So again, you have this relationship which is sort of seems to be go in both directions. Moving on to clinical populations, many of you I know will be familiar with the STAR-D study. This is an outpatient depression treatment trial in the United States. And as you can see here in this first column, this is the people who just had depression. So about 40% of their whole sample just had depression. 42% had depression comorbid with anxiety, 6.9% had depression comorbid with a substance use disorder, and they didn't differentiate between alcohol and other drugs. And then you've got about 10% who had comorbidity of depression, anxiety, and substance use disorders. And as you can see from this, the impact that the comorbidity has on people in terms of the fact that their onset of illness is likely to be earlier, as we've already seen with those community studies. Their length of episodes are likely to be longer. Their percentage attempting suicide is greater, and the likelihood of remission is substantially less. So a real impact in terms of outcomes. And when we think more broadly in terms of the contribution of alcohol use disorders to suicide, our kind of specific mortality really in psychiatric disorders, alcohol use disorders confers a 9-time increased risk of suicide, And the chart here shows data from the Global Burden of Diseases study. And as you'd anticipate, depression, major depressive disorder, both direct and attributable is the greatest contributor to suicide. And then alcohol use disorders and anxiety disorders, come close seconds and thirds to that. Alcohol use disorders, as we also know, are associated with repeat suicidal acts, as well as increased mortality following an initial attendance at the emergency department. Just a bit more thinking about this in terms of the National Confidential Inquiry into Suicide and Homicide and their more recent report here. And again, just a reminder that, of patients who die by suicide within mental health services, almost 60% of them have a co-occurring substance use problem. And, this is something that every serious untoward event review seems to bring up. It's the comorbidity that is the challenge. And in addition to that, though, we have the situation whereby patients who are intoxicated when they present following an episode of suicidal behaviour are more likely to be sent home. There's often a barrier to them accessing crisis care. And as well as the fact that from the patient perspective, there's this sense of perhaps being stigmatized by health workers because of the perception that they are difficult or manipulative or unmotivated to change. And I think this stigma really constitutes a barrier to patients accessing the care that they need. And a final piece of data, which comes from the South London and Maudsley service data, which I thought was a really interesting and again, slightly worrying kind of picture, which is that there's a significant delay in both being diagnosed with a diagnosis of bipolar disorder and then a significant delay in treatment for bipolar disorder if you have an additional alcohol use disorder on top of the bipolar disorder. As you can see there, it's small numbers in terms of the overall numbers of patients with bipolar disorder. And that, I think, is another thing that we could discuss, which is that it may be that some patients have not been adequately screened and their alcohol use disorder has not been picked up. But for those for whom it is identified, there's really quite a substantial delay there in terms of both diagnosis and treatment, which in itself we know will have an impact on their overall outcome. And our chairman of today and his colleagues, have written an editorial, and there have been many over the years written about this, which is that we really need to kind of have an inclusive and comprehensive approach to identify and manage patients with the comorbid condition. In my role as chair of the addictions faculty of the Royal College of Psychiatrists, every time we get the next set of data out which show that drug-related deaths or alcohol-related deaths are at an all-time high, and that there's this number of patients who really fall through the cracks of both services. We end up kind of writing sort of more opinion pieces on this to try and sort of move the agenda further. And as with everything, COVID has really demonstrated the inequalities that are already there in the system. And sadly, at the moment, I think things are worse rather than better. And the important thing about this is that what we have is that patients are excluded often from mental health services until they have sort of resolved their drug and alcohol disorder. But they can't then access addiction services because these are not commissioned as crisis services. And, the staff don't have the training really to deal with people who have mental disorder. So it's a real lost opportunity and a tragedy really for many people and their families. So moving on to the kind of the solutions, but, just to pause briefly as to why we don't have care for comorbid alcohol use disorders. And I think, outside of perhaps mainstream psychiatric services, it's a real surprise to people that actually this isn't dealt with within mental health services. Stigma I've already mentioned. I think a lack of funding for services certainly has an impact, because, you know, where it becomes a form of rationing in terms of where we offer our care. But I think also there is a real challenge now around competencies, and I just want to talk a little bit to that. In 2012, I was privileged to chair a working group of 13 Royal Colleges and faculties, and we came up with these set of 12 core competencies that really every doctor, no matter what field in which they worked, really should have in terms of the management of alcohol and other drug use. And I won't go through these now, but I just wanted to highlight in blue the things that I think are really kind of key to this, is that from a knowledge perspective, we just need to be aware of the fact that, you know, alcohol is a very common presentation, and it has such a potential for harm in terms of our patients presenting with psychiatric disorders. In terms of skills, I think we do need to be competent to make an assessment of alcohol, and, you know, perhaps using validated tools to help us with that, to be able to provide brief advice, and I'll talk a little bit about that in a minute, and management and or referral where appropriate. And we felt it quite important when we were doing this consensus document to put in a little bit about behaviours and attitudes. And I think it's a really basic thing perhaps, but it is as simple as feeling confident and comfortable discussing alcohol and drug use with patients. And it's one of those things that the more we do it, the more confident and comfortable we feel. And the less we do it, the less confident and comfortable we feel. And I think that's my plea really, is that the more often we can do it, the more we just make it into mainstream practice. So how can we put some solutions in place? And that's what I just want to talk about for the rest of the talk. So I think in terms of key management, pretty much every policy document, certainly within the UK in the last 10 years, has talked about these three things: that really co-occurring substance use disorders, and particularly alcohol, really should be the expectation and not the exception within mental health services. And then these two other kind of phrases that have found their way into many related documents, that it's everyone's job for us to be able to, we have a joint responsibility, and that from the patient perspective, there's no wrong door, and that wherever somebody turns up for treatment, we should be able to recognise the co-occurring condition and be able to adequately assess it and ensure we can integrate or refer for them to have the appropriate care to best improve their chance of positive outcomes. So just thinking a little bit about what that means in terms of general principles to us when we're seeing a patient. And I think first and foremost, screening for alcohol use is integral to every clinical history. And where appropriate, making a full assessment in terms of the quantity, the frequency, and the duration of use. Any associated harms that the person or their family may be experiencing, those are physical harms, psychological harms, or social harms. And I think a really useful thing is previous attempts that people have made to stop or cut down, and the success or otherwise of these, because it tells you a lot about the natural history of the disorder, but also kind of some of the explanatory models that the person may have. And this idea of explanatory models, or the patient's view of their substance use, is really, really important. And it may differ from ours, and that's an important thing to remember. Some people will absolutely see it as problematic, some people will see it as social, and some will very much frame it within a context of their self-medication for their other mental illness that they may be presenting with. I think it's really important to kind of take that on board and see how it changes during treatment, and then try and actively address both, if not all, of the conditions that people present with. So just to say a little bit about identification and brief advice, IBA. It's sometimes called SBI, screening and brief intervention. They are exactly the same thing. They're used variably and interchangeably as terms. The way I like to think about it is that IBA is very much about having a clinical conversation about alcohol. There's nothing kind of magic about it. It's just about talking to patients about their alcohol use. And if we ask everyone about their alcohol use as we do about smoking, it helps with that. I think as part of that, one of the skills that we really need to kind of brush up often is to be able to accurately quantify people's alcohol use in terms of their volume, percentage and frequency. Happy to discuss that afterwards. It sounds more complicated than it is, but I think it's really important that we write in the notes, you know, this person drinks approximately 3 units of alcohol 3 times a week, or they drink 30 units of alcohol daily. I now work in an acute trust in a general hospital, and you know, every week I see ETOH+++ or occasional binges. Please see. And, you know, that gives us no objective evidence for where the patient is. The use of the structured tools, such as the consumption questions of the audit, which I'll come to in a minute, is often really helpful in framing that conversation. And then really it's about feeding back to the patient how much they drink and reflecting on that. And if there is a high score on the audit, or somebody is drinking a substantial amount, that's when you need to perhaps assess further for both whether they need a medically assisted withdrawal and potentially the possibility of alcohol-related brain damage. So this is the Audit C for those of you who are not familiar with it. As I said, it's the first 3 questions of the 10-question audit, which is the WHO screening tool. It nicely asks, you know, how often do you have a drink? How much do you drink when you drink? And how often, if you're a woman, have you had 6 or more units on a single occasion? And if you're a man, how many times have you had 8 or more? This can give you a score out of 12, which is quite useful. But as I said earlier, perhaps the most useful part of it is that it just helps you structure a clinical conversation with the patient in a non-stigmatizing way, and in a way that gives you quite a lot of objective information that you can then use in terms of further management planning. So having screened people, the next thing would be to think about, in those who are drinking at quite heavy levels, whether or not they're going to need a medically assisted withdrawal. And, you know, my ballpark figures for this are if people are drinking daily or near daily 10 or more units, although that's going to be less in the elderly. If when they stop drinking, they're already a bit agitated and craving or irritable. And I think it's just key to always have it on the differential diagnosis list. You know, as I said at the beginning, over 80% of people in the country drink alcohol, so it should be on the differential diagnosis list. This is not going to be a rare event. If somebody is drinking heavily, be mindful of the likelihood of them having Wernicke-Korsakoff syndrome or other alcohol-related brain disorders, such that, you know, they may be confused and have some cognitive impairment. And the recommendation for that group is that they have parenteral Pabrinex really as soon as possible. It may seem silly, but, you know, every mental health trust has a trust policy, and it's worth dusting it out and finding it and following that policy, because for most trusts that will involve a standard reducing regime, which is probably the safest thing to do for a patient. But as part of that, therefore, you need to monitor and review that symptoms are settling. Because if they're not settling, you need to increase the dose. And if the patient's getting a bit knocked off, you need to reduce the dose. And I think the final thing to remember about medically assisted withdrawal is that it's only the start of treatment and not the end of it. And we need to be thinking about relapse prevention, which I'll come to in a minute. Before doing that, though, I just wanted to show you this, what I think is a really helpful summary from the Australian alcohol guidelines, actually, and particularly here on the right. It just reminds us that the presenting complaint for many patients may well be a seizure, and that tends to be in the first 48 hours of stopping drinking for people who are drinking very heavily. For the majority of people, and particularly those that you'll see in mental health services, it's this course, this relatively benign course, that will be taken for the majority of people going into alcohol withdrawal who present with another mental health problem. And so most of those with a reducing regime will settle quite quickly over 2 to 3 days. Where the problems begin, and this is what we see more of in the acute settings, where people are presented with other physical health problems, and they might be septic and, you know, have other things that put them at risk of severe withdrawal, is that when those symptoms don't start to settle after 3 days but are getting worse, these should be ringing real alarm bells for people, because this is when people become at risk of delirium tremens, and then, you know, we're facing a medical emergency, and it needs, for phenomenally high levels of benzodiazepines. And I suppose, you know, to remember one thing, and I'm very happy to discuss afterwards, it's really, if the benzodiazepines aren't working, give more. Obviously, you know, respiratory depression aside, you really need phenomenally high doses of benzodiazepines in people who are going into severe withdrawal. And I think sometimes in psychiatric settings, we move a bit too quickly to giving antipsychotics. And whilst they may act as a chemical cloche, they're not going to really help with the underlying kind of GABA disruption that's ongoing. And so I think that is always key to remember in treatment. There's a nice summary here, which I won't go into, but you can have read. And the other thing that I would really remind everybody about is the fact that, you know, dehydration and electrolyte imbalances can really kind of significantly worsen outcome in people. So there's a need to monitor that as you go forward over the next few days. The Prescribing Observatory for Mental Health, POMH UK, many of you will be familiar with. It is a quality improvement program, and back in 2014 they did a baseline audit about how medically assisted withdrawal was managed in patients in psychiatric units. It was re-audited in 2016, and in fact this year the audit is also being repeated, so it's worth thinking about this now. The first thing is, if I present the findings from the re-audit in 2016, which to be honest were pretty similar to the baseline audit, the vast majority of people were managed in a psychiatric hospital, you know, having been admitted for another reason. So it was an unplanned detox, and 96% of these were undertaken by non-specialists in non-specialist general adult wards. I think one thing to point out is that 1 in 5 of those was the first known detox. So a real opportunity to change the course of the illness, and something I think if someone's in for their first detox, it's just great to really try and make the most of that. Unfortunately, most of the quality standards, the recording of what had happened at any rate was not particularly great. 20% patients had no documented alcohol history, 15% had none of the recommended blood tests taken, a third had no documentation of any of the signs of Wernicke's, and almost half didn't have a documented standardized assessment tool used. So for instance, the CWAR, which is the clinical instrument for withdrawal from alcohol, or the severity of alcohol dependence questionnaire, or the audit itself. And the other thing that was shown, which was worrying, is that evidence-based interventions were much less likely if managed by non-specialists. So in terms of, you know, what should perhaps be being done, I just want to finish by presenting a couple of things which had an impact on my practice, and then thinking about how we integrate treatment more broadly. So the first thing to say is that, you know, any management of alcohol dependence and relapse prevention happens within a psychosocial framework, as it does for all psychiatric treatment, I would say. The most recent Cochrane review of the psychosocial treatments in people with co-occurring psychiatric conditions and substance use disorder shows that no intervention was found to be superior for either treatment retention or substance use disorder or improving mental health. That doesn't mean that none of them was effective. It means that no intervention was superior to any other, so no particular mode of psychosocial intervention. And I think this is a helpful summary from an older narrative review, but essentially it says that, you know, if a psychosocial intervention works, say, in depression, it's likely also to work in depression if the person has an alcohol use disorder. And similarly, a psychosocial intervention that works for alcohol use disorder is likely also to work in alcohol use disorder if that person also has depression. But when we think about the pharmacological treatments for relapse prevention, this is a table from an article that we wrote for Advances in Psychiatric Treatment last year, if people want to follow that up. But we have, from the NICE guidelines, acamprosate and naltrexone are the first-line treatments in the non-comorbid condition. And to be honest, I can't see a reason for not using those in patients with a mental illness. And in fact, in the recent BAP guidelines for bipolar disorder, naltrexone was put as the first line treatment, just partly about the use of in patients with bipolar disorder about their likelihood of perhaps being samplers rather than maintaining abstinence. The biggest thing to remember with naltrexone and also nalmefene, which does have a license for use in the UK and in most of Europe, is that you need to check that patients aren't on codeine-based medications or any other opioids, because obviously they're opioid antagonists, and so there'll be an interaction there. Disulfiram, it's interesting in terms of, you need to do a good risk assessment, obviously, in terms of patient engagement and any suicidal ideation. But actually, the earlier concerns that there were about disulfiram precipitating psychosis don't really hold out with modern doses. All of those case reports were very much based on the fact that disulfiram used to be given at doses of 2 to 3 grams a day, whereas now we use about 200 milligrams. And then finally, the only one that I would put with a health warning is baclofen. I do prescribe baclofen. Baclofen's a bit like Marmite. People either love it or hate it. I sit on the fence, really. I think it's a really good drug in the right people, but it's also a drug that I wouldn't use primarily in a group of people with mental health problems unless you had quite good expertise in using it, because it can precipitate hypomanic states, and there's a really quite a significant risk of severe respiratory depression in overdose. So I think you need to be cautious in using it. Just want to quickly present this study, which I think for me is an important one to make the case for using a combination of treatments. That, in other words, if someone has depression and an alcohol use disorder, treat both. Don't hope that one will get better if you treat the other. And this was a lovely study by Helena Pettinati. It was done in American veterans in the States, but essentially it treated people with sertraline and naltrexone, they're in blue, naltrexone only with a placebo instead of sertraline, sertraline only with a placebo instead of naltrexone, and then placebo for both conditions. As you can see, there was a high dropout rate, but that wasn't different between any of the groups, so we wouldn't anticipate that that would affect the difference in the groups. And what you can see is, if you look at this on the top right-hand side, this is the proportion of subjects without a heavy drinking day. And so in terms of the higher up on the graph you are, the better that is. And what you can see very clearly here is that there was a significant benefit for those patients who were treated with both active component medications. So patients on both sertraline and naltrexone did significantly better than patients either on sertraline alone, naltrexone alone, and neither of those differentiated from those on placebo. And as I said, this really changed my practice in terms of thinking about actively treating both conditions. And this is the HAM-D score, change from baseline. As you can see, there's an improvement over time across all the groups. It doesn't reach significance, but I think I would say with the eye of faith, by the end of the 14-week, it's starting to show a benefit for the combined group. So I think if we're thinking about how we optimize treatment at a system level, hopefully I've made the case that identification and a system-wide screening of all our patients is a really, really important way of just trying to, kind of move things on in terms of identifying patients who may benefit from some, however brief, intervention around their alcohol use. And using a structured tool such as the audit is really helpful in starting those clinical conversations. I think we need to make management an integral part of the treatment plan, and whether that's as part of our own team or in combination with a wider team, that will depend on the severity of the individual presenting. And we actively need to manage both conditions within a psychosocial framework, as for most of psychiatry, but also using evidence-based psychopharmacology. So in summary, alcohol use disorders are common. They're disabling, co-occurring conditions in psychiatric practice. They are the expectation and not the exception. They're associated with delayed diagnosis, delayed treatment, and worse outcomes. And systematic screening for alcohol use, I think, will enable appropriate interventions to be integrated into a much more holistic management plan, rather than us sort of, dealing with it when we can't avoid it any longer. I think it requires us to reskill ourselves and our teams in some of the basic competencies around this. And I'm very happy to talk about this further, just to improve our confidence in talking to patients, because by doing so, we'll also increase our competence in managing patients with alcohol use disorder. And I think as part of that, it's about engendering a culture of therapeutic optimism within the service. I think people often have quite therapeutic, nihilistic views about patients with alcohol use disorders, which really is not my experience of them. The ones who do really well, it's just we don't see them again. And so we have strange negative feedback loops. So finally, I think we as psychiatrists need to reclaim alcohol use disorders primarily as a disease of the mind and genuinely embrace person-centered care. Thank you very much indeed.
So thank you very much, Professor Sinclair, and great to have you here. And we've got 10 minutes of questions before lunch. So, and there's quite a lot of questions. So firstly, is the exclusion of alcohol drug dependence from the Mental Health Act an example of stigma? Shouldn't this be a mental disorder, not a lifestyle choice?
Gosh, that's a good one to start with, isn't it? So that's a really interesting question with regard to the Mental Health Act, because it has been excluded. And obviously with the recent review of the Mental Health Act, nobody thought about putting it back in, if you see what I mean. It wasn't on the table for discussion. So although there was some suggestions about it, I mean, at one level, yes, it is. And in terms of the fact that it's not a lifestyle choice, obviously part of the definition of an addiction is that you carry on doing it even though you know that it's doing you harm, and the loss of control. And so you could make parallels with an eating disorder that, people are choosing not to eat. And so why would we be using the Mental Health Act for it? So I think it is, at one level, I would agree with that. I think, though, at the other level, there is the challenge in the same way that you have with some other mental disorders, which is how useful will the Mental Health Act be in terms of addressing it? So as a pragmatist, I would say, well, we know that kind of putting people into enforced treatments doesn't tend to have particularly positive long-term outcomes. And so in terms of that, it's probably not that helpful to have it in there, but it would be nice in terms of being able to not just have this dichotomized view that it's an alcohol use disorder, therefore you can't use it. It would be helpful if there was a slightly more nuanced view. And I suppose people, when they choose to, do use that. So if somebody is acutely suicidal, you can actually still detain somebody under the Act if you think that, their depressive symptoms are such that justify it. But yes, I think at one level it's interesting that it's always just been without the Mental Health Act.
Yeah, I suppose the other thing, and there's a question really about this, is withdrawal. So I suppose if it's withdrawal resulting in psychiatric symptoms or delirium or whatever, you could use the Mental Health Act. Otherwise, you might need to use the Mental Capacity Act. Would that be correct? Or?
Well, I mean, I think I was dealt with somebody in DTs last night at the General Hospital, and to be honest, they were there on a deprivation of liberty safeguarding for their own health, for their own safety. So you've got the DOLS use in terms of people who are acutely delirious. I think the Mental Capacity Act is helpful in terms of particularly some of the self-neglect aspects of it. But I think it still remains, I think there's a lot of work to be done, and I'd be really keen to see some ethics development of this over the next few years. There's an American ethicist, Linda Farber Post, who says, honouring the wishes of a person with capacity demonstrates respect for the individual. Honouring the wishes of a person without capacity is a form of abandonment, and the distinction insofar as it can be reliably made is critical. And I think this has always been the challenge with alcohol use disorders, is around, particularly by the time somebody's dependent, is just that whole thing around they continue to drink despite evidence of harm, and trying to square that circle.
Yes, and that questioner said that they applauded your presentation, which is
Thank you. That's kind.
Nice. Also, there's a question, should we be using the term misuse, not abuse?
No. So I think in my presentation, I did use the term abuse because I was using that as per a study that was presented, which was the old DSM-4 criteria. So as a diagnostic term, DSM-4 divided patient groups into those who abused, which in ICD-10 was harmful use of, and dependence, which was the same in ICD-10. DSM-5 has moved on to alcohol use disorders. And absolutely, I only ever use the term abuse as a diagnostic term when I'm reporting a study. But I do agree we should not be using the term misuse. It's quite a stigmatizing and sort of effect of the criminal justice system, because we have this, the Misuse of Drugs Act, but in a health perspective, and the GMC has now also embraced this terminology. It's about talking about alcohol use and alcohol use disorders.
Yes, I specifically used to talk about alcohol misuse when my father-in-law drank my malt whiskey because he didn't appreciate it.
Absolutely. Misuse is always something that somebody else does.
Yes, that's right. Now, the audit relies on an accurate understanding of what a unit of alcohol is. Our medical students are useless in this regard.
Yes.
Do doctors really understand this?
No. That's a really good question. I'd say actually that our medical students are rather better than most of our colleagues, actually, mainly because we teach them on it. Well, I teach them on it at great length. But, nationally, I think medical students are slightly better at it. We did an audit at the General Hospital 3 years ago now. We flash mobbed the wards. We stuck an iPad under people and we got them to give the units for 4 commonly consumed drinks. And out of the 400 odd people that we surveyed, I think 7 got all 4 of those drinks right. A third of them could only get 1 of the 4 correct, and another third got 2 correct. So I think we're really bad. We've really got poor alcohol specific literacy or numeracy in this area. And I think that's partly the drinks industry, who's very keen that we just think about alcohol as an experience and not as a drug dosage. But I would always encourage people to learn drug dosage and also to, for many patients, actually, they're okay at knowing what they're drinking in terms of percentage and quantity. And I do think it's a core medical competency that we can change that into units of alcohol, and much more work needs to be done.
Has it helped putting the units on bottles of wine? I mean, I now slavishly look at the bottle of wine and calculate how many units, but I'm aware that I'm a bit strange at times. It's a bit like the calories on food. You can tell how much is in a sandwich. Is that helpful generally, or is it just for oddballs like me?
No, well, I think, if you're an oddbod, Alan, I'm a complete nerd in this, to the great upset of my husband when we're going out places. But, I think it's helpful. Information is power. And I think where the drinks industry have got really far behind is that they were meant to have upgraded all of their backs of their bottles to say that actually lower risk drinking is now 14 units for men and women. And this was obviously a voluntary code, and it was all meant to have been done, I think, by some point at the beginning of last year. And the most recent survey on that still had about a third of bottles still saying that actually lower risk drinking in men was up to 21 units of alcohol. So if you think how often they change their labels, but they haven't been able to change this 3 years after they took on that as a voluntary code, I think it tells us something.
Yes, one thing that strikes me is that the alcohol percentage in wine and beer has crept up over the years, and it makes a big difference. I mean, there's the occasional bottle of wine which is still 10, 11%, but they often seem to be 14, 15%, which makes considerably more units of alcohol per bottle, really.
It does, and I think particularly, the first public health messaging about this came out in the 70s, and at that point, why some people still think that 1 unit of alcohol is a glass of wine is based on the fact that it was based on alcohol wine that you bought, English table wine that you bought in the 70s in pubs, which was really not something that anyone bought. It was 8%. And the glasses that it came in were 125 mils, and that remains a unit of alcohol, 8% alcohol at 125 mils. But as you say, if it's 14% and it's in a 250 mil glass, you're looking at 4 units of alcohol in your glass of wine. Big difference.
Yeah, I've certainly noticed in the United States where the beer used to be incredibly weak alcohol-wise, that they now have craft beers which can be 10, 11% alcohol. Now, I think you covered this in your lecture, but which medications should general psychiatrists use for relapse prevention? What would be your top tip?
Well, I mean, as you said, I gave the four that we have using. Acamprosate is a really safe drug. It's got a good evidence for effectiveness. It doesn't really interact with very much. And as part of a broader kind of psychosocial relapse prevention, I think it's a really good one. Often people think it's not particularly effective. And I think that's not borne out by the evidence, but it's more to do with two things. Firstly, if people try it, they tend to try it in the patients that they've tried everything else for, and they're finally trying acamprosate, and guess what? It doesn't work. It has a number needed to treat of about kind of 8 to 10, as many psychiatric drugs do. So it's no less effective than other drugs that we use. But also, I think it's about the fact that because it reduces cravings, it's often hard, and for the patient to say that it's doing anything. I'll say to my patients, how's the acamprosate? I'm not quite sure what it's doing. And I said, well, do you have any cravings for alcohol? And they said, well, no. And I said, well, that's probably what it's doing. So if it's working, it gives you an absence of something. And so it's often hard to tell. So I think acamprosate's pretty good, but that's very much for maintaining abstinence. Naltrexone, I think, is probably better in bipolar disorder because that is much more about preventing relapse to heavy drinking by a kind of feedback loop. So those would be my top two, and those are the ones recommended by NICE.